Sadly lost Allison. Allison now is over at Metro Health, and we lost her as a faculty member. But before she left, she had created an awesome talk on the Master's Athlete and Adaptive Athlete, which covers a lot of CAQ topics and is important for your studying. So she was kind enough to join us virtually for our lecture today. So I will let her take over. Thank you for your time.
Awesome. Yeah, thanks for having me. It was good to catch up always. So this is like pretty, I try to say very board relevant. Obviously, you see a lot of older people in clinic, but you're not always thinking about the pieces that they're going to ask you about on boards. And then from adaptive athlete standpoint, like I'm not teaching you all to be PM&R sports med or PM&R trained in this time. Like this is just going to be hitting the things that they're probably going to ask you about on boards and then giving you some like background knowledge. So if you are ever covering adaptive events in the future, you know like where the resources are pretty much. So we'll talk in the Masters Athlete. They ask a lot about physiology on boards and the effects of exercise, especially exercise and chronic diseases. I feel like a lot of my physiology questions were like in this realm on the board exam. And then for adaptive and disabled athletes, we'll talk about definitions and then high yield pathology that you'll probably get asked about. So I'll start with the Masters Athlete. Um, and there are a lot of Masters athletes around. I feel like in clinic, I see a ton of people who are rec athletes, like 40 to 60 or 70. And this is just a graph showing that the number of people completing marathons is increasing. And, pickleball, there are a bunch of sports that people are trying to do to stay active as they get older. And with that comes injury. Um, with the reality of aging, I kind of adapted this and added my own things. But we think about like our high school and college athletes put a lot of stresses through their body. Um, but once you're getting older, there are different things that affect you. And so there are lifestyle factors that play a big role where like now these masters athletes have kids and families and full-time jobs and they're trying to train and they're trying to compete at the level that they used to, but they don't have the resources. They're not taking the recovery time. Their actual commitment to training is less, even if they feel like I use running, for example, because that's what I like. If you feel like the volume is the same, but I don't do all the little things that I used to do in college to keep myself healthy. You have the natural aging process, and we'll talk a lot about the physiology of aging. And then a lot of times our training intensity and volume have to decrease as we get older. And so the other things that are happening at the same time as this is our cardiovascular function is decreasing as we get older, and biomechanical function is also decreasing. And even some of the lifestyle factors can affect those. So, you're not eating as healthy as you used to, or training the same way, or you're not stretching and doing all the little, I call them little things, in addition to just going and playing the sport or doing what you want and enjoy doing. The natural aging process affects these, and then the training intensity and volume affects these. And all of this affects activity and performance. And so I can count on one hand the number of times in one clinic, like a half day of clinic, where someone comes in and they're like, well, I used to be able to do this and now I can't do it. And it's like part of that is just unfortunately when you go from 50 to 60, like your body starts to not work the way that it used to. But the hard part is that all of these lead to increased injury risk. And so we are seeing athletes back who don't have the time, don't have the training commitment. They're like aging and functioning not the way that they used to. They're getting injured and then they, get frustrated. And then that feeds back into the poor performance and the decrease in training volume and intensity. And the biggest thing as people age that they don't think about a lot are these lifestyle factors. And so also people like, I don't know, I feel like every single sacral stress fracture that I've seen in someone, they've had like some major life event that's contributed. So when we're thinking about optimizing health and performance, we kind of think of this U or J-shaped curve where the current exercise guidelines, so 150 minutes of moderate activity, 75 of vigorous activity with 2 days of strength training a week, put you somewhere over here trying to optimize that health risk. We get to a point where you're exercising and it's really beneficial, but if you are on extreme exercise, this is the extreme exercise hypothesis, then you're at higher risk of getting injured or even like cardiovascular events like AFib and other things like that. And so, we're trying to keep people here, and we start to often see people when they're on either side of this curve. Either they're not exercising enough or they're pushing it too much. Um, so I'm going to go through some of the cardiovascular, respiratory, metabolic, MSK, and neuro aging processes. These are like super board relevant. A lot of them are kind of common sense if you think about it, but there are going to be questions related to one of these on the boards. This is where they get a lot of their physiology from. So cardiovascular wise, a lot of these, excuse me, things make sense. Like as you get older, the your max heart rate decreases, blood vessel compliance decreases, resting stroke volume decreases, maximum cardiac output decreases, total plasma volume decreases, which increases your dehydration risk. I've seen questions on like the 10 beats per minute per decade for the heart rate decrease, and then usually they're probably not going to ask you like specific numbers for other of these, but they'll ask you which direction do all of these things go as someone goes from 40 to 60. And then another thing that's really highly tested is the Carbonian formula. You're probably going to have to calculate some sort of target heart rate, whether it's for a master's athlete or not, where that is the max heart rate minus resting heart rate times the percent intensity that they are exercising at plus the resting heart rate. So it'll be like you have a marathon runner who is trying to hit 80% intensity. What is their target heart rate when their maximum heart rate is X and their resting heart rate is Y? And we
Yep.
have to
So
plug
I
them into this.
I had that question on my test, and I had to use the age in order to calculate the max heart rate. So you had to go a
Yeah.
step further, and they wanted you to do 220 minus age also.
Yeah.
So that right there is like 1 point. You just have to memorize it. And as soon as you walk into the test, you use your little whiteboard and you write down the formula as fast as you can. So it's there when you hit the question.
Yeah. Yeah. And the 220 minus age actually comes from this decrease in max heart rate by 10 beats per minute per decade. So you're decreasing that from the 220 as people get older. Respiratory wise, we get an increase in residual volume and a decrease in vital capacity. And so, again, like a lot of these, you don't have to sit here and memorize, like they're common sense. Like, even with the cardiology, like vessels get less compliant, like things are less elastic. You can't reach as high of a heart rate because your heart's not able to work at the function that it did before. From a lung standpoint, that also makes sense. Like the residual volume increases where and vital capacity decreases when you just think about as you get older, like your endurance decreases and then what things kind of change with that. Um, so you don't need to memorize, but if you understand, and I say common sense, but think about it. From a metabolic standpoint, your VO2 max decreases. That's about 9% per decade. And then glucose tolerance decreases, so diabetes risk increases. Like these are common, I say common, like common sense, doctor common sense things. But they might ask you questions about it. And sometimes they'll give you like what goes up, what goes down, and a bunch of different combinations that you got to figure out. From an MSK standpoint, bone loss also occurs between 35 and 55, but occurs more quickly after 55. Muscle mass, fiber size all decrease. So you lose about 20% of your muscle strength by 65, which includes losing speed and power, and tissue stiffness increases, so your flexibility decreases. And again, if you just think about what happens as you get older, you get tighter, you get weaker, and then work backwards to the physiology of why that happens. From a neuro standpoint, you have decreased proprioception, walking speed, reaction time. Therefore, your balance is off and you're a higher fall and injury risk. Again, kind of common sense. You think about people walking into your clinic when they're 80 or 85 versus when they're 65, and you can kind of figure out which way these things go. From a body fat standpoint, you have an increase in body fat between 30 and 70, therefore higher BMI, higher cardiovascular risk and metabolic disease risk. And then after 70, the body fat actually decreases again. And if you just think about the patients that you see in clinic, this makes sense. So there are multiple positive effects of exercise. So we can't fully flip the aging process, but you can slow it. So exercise will decrease the cardiovascular and MSK age-related decline. It's still, I always tell patients it's going to happen, but it can happen more slowly if you're working to change that. Exercise increases insulin sensitivity, so decreases risk of diabetes, increases good cholesterol, lowers bad, helps with weight management, mood, cognition, physical function, decreased falls, and then improving sleep quality, which also declines as we get older. So basically does the opposite of what aging does. You just can't fully reverse it. And then thinking about regular exercise and the long-term impact on cardiovascular disease, a lot of these are also board testable, and they'll often test the contraindications to exercise, where, again, some of these I think are like common doctor sense. If you have severe atherosclerotic cardiovascular disease, probably shouldn't be exercising. If you have unstable angina, probably shouldn't be exercising. Severe aortic or carotid stenosis, myocardial ischemia, despite being on medications. If you're in a CHF exacerbation, or if you have CHF with hypertension or hypotension at rest, or with activity, uncontrolled arrhythmias or uncontrolled hypertension, cardiomyopathy, myocarditis. And then if you're on anticoagulation, you'd have to talk about contact sport risk. And again, these, are things that I feel like clinically makes sense. From an exercise and dementia standpoint, I've seen questions about this. Exercises reduces risk of dementia, improves cognitive function in ADLs, and it's actually the first line treatment in cognitive decline. So the question I've seen is like, what is the first line treatment of cognitive decline? And it's like, you know, therapy for memory and, medications and other things. And the answer is actually exercise. The things in red are often things that are highly testable, so that you'll see in these next couple of slides, and a lot of them are the contraindications. So hypertension, exercise will decrease systolic and diastolic blood pressure to help control chronic hypertension. Endurance, dynamic resistance exercises, isometric strength testing all improve blood pressure. And aerobic training as well improves blood pressure. Do not have someone exercise if their blood pressure is over 200 over 110 until it's pharmacologically controlled. And again, I think like those people are going, you know, potentially to the ER, especially if they're developing other symptoms, right? Like you're not going to put them on a treadmill and have them run or walk. Coronary artery disease wise, cardiac rehab improves cardiovascular mortality, decreases hospital readmissions, cholesterol, triglycerides, and systolic blood pressure. Typically, after a CABG or a stent, you'll start 1 week after a stent and 4 to 6 after a CABG. But again, contraindications are the same thing as contraindications to exercise in general: severe coronary artery disease, unstable angina, severe aortic and carotid stenosis. And you're like, we do sports medicine. Why are you telling me about all these chronic things? But these are questions that you could get asked on your sports medicine boards because it's related to the exercise prescription for patients with this medical condition. So in CHF, exercise improves VO2 max, blood pressure, ventilation, resting heart rate, but does not actually change mortality. So people who do cardiac rehab with CHF, their mortality doesn't change, but you get benefits in other areas. Contraindications, again, class 4, heart failure, worsening dyspnea if they're gaining weight, and if they're getting ventricular arrhythmias when they're exercising. Those, again, I think are like common sense doctor um, things. From a diabetes standpoint, lack of fitness is an independent risk factor for mortality with diabetes. Exercise in general improves all of the types of exercise, improve basically everything related to diabetes, insulin resistance, blood pressure, increases VO2 max and strength. Again, cautions are monitoring blood sugar during and after exercise. cushion footwear, and don't inject the insulin into the exercising body part. So I've seen that on a question too of like maybe it's not a master's athlete, but you have another athlete who's diabetic, what should you do to treat them? And it'll be like administer insulin shot into abdomen, administer insulin shot into leg, and then, other medications to treat them with. And you just want to make sure it doesn't go into whatever body part they're using to exercise. From a COPD standpoint, with quality of life, but not pulmonary function is improved with pulmonary rehab. I've seen that question come up on sports boards or practice exams. The pulmonary rehab reduces fatigue and dyspnea, but it does not change quality of life. And then there's no difference between aerobic versus resistance training as part of the pulmonary rehab in people with COPD. Peripheral vascular disease, with this, you get reduced tissue perfusion, slower walking, and less ambulatory time. So people are not exercising, but exercising, usually a gradual progression of increased time or distance, improves pain tolerance, fitness, strength, and then walking distance, the program for this is a supervised program where you have them walk until the point where things start to hurt and then go a little bit farther and then rest. And then you do it again to try to get their body to develop collaterals um, to overcome the peripheral vascular disease. Joint arthroplasty, the questions you're going to see about this are which sports can you do or not do post arthroplasty? I'm not going to read them all off, but what they typically will list is you can play doubles tennis, but not singles tennis. I don't think they're going to ask you about something that is kind of controversial. Like my colleagues who are in Utah joke that if they ever told someone they couldn't ski after a joint replacement, they wouldn't have any clients, like they wouldn't have any patients. Whereas like in Cleveland, it's probably a little bit more common to say, oh, you shouldn't downhill ski after you've had a joint replacement because just the number of people who are doing that frequently is less. Um, so we have questions here. If we can just go down the line. And if you want to read the question and answer it, and you can phone a friend with your other fellows if you want. Does someone want to volunteer to go first, or I can call on you?
Bingo. So this is a 70-year-old patient who is still running half marathons. He reports that his running pace has slowed significantly, but he remains injury-free. All of the following are physiologic changes seen with aging, except. So, kind of going through, he's got, I think he is going to have some decreased muscle strength and flexibility. A lot of the numbers I don't remember off the top of my head. So, VO2 max I know is going to decrease, maximum heart rate is going to decrease by 10 dBs per minute. So I don't think it's C. Residual volume 30 to 50 by H70. I think that one was also correct. So I'm going to go with B.
So it's
Oh,
actually
D. Okay.
D. Yeah. So when you think about residual volume, right, that's what's left in your lungs. So anyone who did adult medicine and now doing sports medicine thought that you could forget completely about this uh, breakdown of lung volumes. So we think about our vital capacity, that is everything that the lungs can inhale. And the residual volume is what's left after that. And so as we get older, that vital capacity decreases, so the residual volume will increase. Does that make sense? You got to pull this like back out of the brain from residency. So you have total lung capacity is residual volume plus that vital capacity. The vital capacity decreases as we get older, so residual volume increases. And then all of these, like inspiratory reserve, resting tidal volume, expiratory reserve, all like decrease as well because that whole vital capacity is decreasing. You will not probably get an accept question on the actual boards, but I feel like they're good for testing like knowledge. So there are a lot of accept questions here.
I can go.
Yeah.
According to the consensus guidelines, all of the following are activities that may be allowed with prior experience post joint replacement surgery, except, oh, I think we just talked about this, downhill skiing. Um, yeah, so doubles tennis is allowed, weightlifting is allowed.
What about running?
Ooh, I feel like jogging was in the shouldn't do
Yeah. Yeah.
category. So I guess depending on where you are, downhill skiing is fine. So C.
Yeah. Yeah. So anything that's like higher impact and the the difference between doubles and singles tennis, like I'm not as an avid tennis player, but the amount of court that you have to cover with singles tennis is just so much more impact and cutting that I think that's why they've like kind of made that distinction between the doubles and singles tennis. And then anything like CrossFit, running, impact things post replacement, they typically recommend against. But again, there's the disclaimer, like final recommendations are at the discretion of the surgeon. So in clinical practice, you might see different than this happening. Like I have patients who have had things replaced and they are definitely running on them. And I'm like, well, it might not be the best thing, but I'm not the surgeon and it's not my place to tell them what they need to do. So this is that list that I gave you. Again, not that you need to memorize it completely. Whoops. But just think about things that are like a lot of cutting, higher impact, or like risk of fracture around the prosthetic site. So a lot of impact sports. I think volleyball's on here purely because of the amount of jumping. And then hockey is like risk of impact. Right. Did I go past? Yeah. Okay. There we go. Next one.
I could go. So, a 70-year-old female, history of osteoporosis and moderate bilateral knee osteoarthritis presents to your office. Which of the following would be most appropriate statement regarding exercise recommendation for this patient?
So we didn't
So,
talk specifically about this, but I think you can probably hopefully decipher and figure it out.
so A, advise participation in a high impact exercise program focused on strengthening flexibility and function. I don't like that it says high impact. Advise participation in a multi-component program that incorporates aerobic exercise, muscle strengthening, and balance training. That one sounds good. Encourage bending and twisting exercises to promote flexibility. And discourage exercise, definitely not the answer. So I would say B.
Yeah. Good. So some of these, like I obviously didn't cover everything, but some of this, like you see this in clinic, you use common sense, like what makes the most sense. And so B is correct. Regular exercise decreases the risk of osteoporosis, um, and delays physiologic decrease in bone mineral densities. Reducing pain and disability with like lower impact activity in patients with OA has been demonstrated previously. And then they need a multi-component that includes aerobic, anaerobic, and balance exercises. And so when you're getting questions on exercise, the most of the answers are like you need a balanced program that includes everything, not just like you only do aerobic or only anaerobic exercise. All right, one more, at least in this one.
All
Who's
right,
left?
so it's my turn. Can you guys hear me?
Yeah,
Okay, perfect. Sarcopenia results in which of the following changes to muscle cells? A decrease in number of muscle cells and increased fatty infiltration. Maybe. B, a decrease in muscle quantity and increased mitochondrial density. C, an increased number of muscle cells and increased fatty infiltration. And D is an increase in muscle quality and decreased mitochondrial density. So sarcopenia means less, I would say.
yeah,
And so I would go with, I think A, but I'm honestly
yeah.
not.
Yeah, it's A. So this is another example where like again, I don't have time to cover everything, but you can like rationalize your way through the answers to get to the correct thing. So when you're taking boards and you're like, "Oh man, I didn't study anything about sarcopenia," but like you know enough like sarco, muscle, penia, less. And so B is incorrect because you don't have increased mitochondrial density. That would improve strength. And then obviously these are incorrect again because there's an increased muscle quality, not the case. An increased number of muscle cells, also not the case. So good job like rationalizing your way through that despite us not covering it. There are a couple more questions in this section, then we'll move on to the adaptive sports. So who went first? Because everyone's done one already. Who went first?
I think I got a little bit of background noise. Which of the following is not a known physiologic change that occurs with aging? Decreased maximal heart rate, a decrease in total body water to 40%, an increase in tissue stiffness and decrease in flexibility, or an increased thirst mechanism. So we know that the heart rate is going to decrease.
I just came back. I was out
Increasing
with
body water.
Thank you. So if you like didn't see anything,
Not
that
A.
was why. But yeah, so back down. That was amazing.
It's not C. And then between A and D, let's say it's not going to be B. So let's see.
It's tough going back, but
Yeah. Good job. D, yeah, so it's D. That was a good job of rationalizing again. If you don't remember everything, but as you get older, dehydration risk increases. So if dehydration risk is increasing, the thirst mechanism's probably decreasing, right? So that gets you to D, but you checked off everything else that was correct. All right, we're going to move on to adaptive and disabled athletes unless anyone has questions about physiology and masters athletes. All right. So some definitions, this is not going to be on your test, but just so you have a little bit of an understanding. Adaptive sports are any sport that's been adapted specifically for a person with disability or created specifically for a person with a disability. A parasport are those that are played at the Paralympics. So some adaptive sports are parasports, but some are not. And then the Special Olympics is separate. That's a nonprofit program for athletes with intellectual disabilities. In parasport, there are multiple different classifications. And again, you just need to know that these exist. You don't need to memorize them or know the difference. But athletes in parasport, so that they're competing against people who are of similar capabilities, are classified based on these various factors and then partitioned into groups. Or if you're on a team, your team has to have, an athlete with this impairment versus a different one. Um, so again, this to me is common sense, but I've seen questions about this where athletes using wheelchairs, they obviously are using their upper body or their arms for mobility. Therefore, their upper body is more commonly injured. Whereas athletes with amputation, they use prostheses for mobility and their lower body is more commonly injured. Like, believe it or not, that might get you a question on boards. Autonomic dysreflexia, you will probably have some sort of question about this. It's like the one adaptive sport thing that they feel like you really need to know, and it's because it can lead to death. So autonomic dysreflexia occurs in people after a spinal cord injury. Their injury has to be at T6, thoracic 6 or above. That's testable. It occurs because there's a noxious stimulus below the T6 where they can't feel normally, and it results in unregulated reflex sympathetic discharge. Also, another thing that's testable. So your sympathetic system just goes crazy, which leads to hypertension, bradycardia, headache, and then the symptoms are headache, blurred vision, nasal congestion, anxiety, piloerection, flushing, and then diaphoresis above the level of the injury. Typically, they don't sweat below the level of their injury. The number one cause, the main cause is some sort of noxious stimulus. And so the treatment, first thing is to remove that. So if someone has a tight belt or tight clothing, you get rid of that. Obviously, there's some noxious stimuli, infection, fracture, that you can't remove quickly. And then medication-wise, we treat with nitro paste. And then oral or IV nifedipine. And the nitro paste is often preferred because you can put it on and monitor their blood pressure and then wipe it off. And if you're ever like practically doing this, you need a glove. Otherwise, you're going to give yourself hypotension. This autonomic dysreflexia is banned in terms of boosting. So you might get a question about that. That's where an athlete intentionally induces autonomic dysreflexia so that they can get that sympathetic discharge, trying to improve their performance. Obviously, this is banned because of the risks of autonomic dysreflexia and the effects on performance. Um, Other common conditions that you might get questions, about. The first one is Verrucous hyperplasia or choked stump syndrome. And they might give you a picture like this and say, well, what do you need to do? And it's socket modifications to loosen the socket proximal to this area of skin. Heterotopic ossification is when you get extra bone within tissue. The first step with this is modify the socket. So these happen in people who have had amputations, and sometimes surgically they can go in and resect this, especially if there are areas that are bothersome. The hard part is that it can come back. Other common conditions in adaptive athletes, primarily those with SCI, are orthostatic hypotension, typically from venous pooling. And again, if you're taking care of these athletes, it's important that IV fluids are on the prohibited list by WADA. So if someone is hypotensive and getting orthostatic, you can't just give them an IV to help them feel better. Thermoregulation comes from impaired autonomic function, where they can't sweat below the level of the injury. And so if they're in a hot environment, they're at higher risk of heat illness. So you might get a question about heat illness, and then you would just need to know the basics of heat illness, recognizing that these athletes are at higher risk. And then they're at higher risk of skin breakdown, pressure ulcers, and then I talked about the verrucous hyperplasia and amputees. Spasticity, it's possible to get a question like this. So spasticity is velocity dependent increase in muscle tone. So what that means is you move a joint, and the faster you move it, the more tone and more resistance you have. There's a grading system for that. That's probably beyond what you need to know. It happens from an upper motor neuron injury, so traumatic brain injury, stroke, um, spinal cord injury, and it can limit their participation in athletics if their spasticity is so bad that they have limited movement, or they can't, like for example, if their flexor spasticity is bad, they couldn't extend a hand or an ankle or something like that. And it can be an indicator, if it's worsened suddenly, of a different systemic illness. So the questions I've seen on sports boards were, they give you a vignette and it's an athlete, and they say something about like the tightness in their arm has increased and they're complaining about that and what is the underlying cause. And they'll give you a bunch of like rotator cuff injury or arm things, but you have to recognize that it's spasticity and there's one systemic like UTI or systemic illness that is actually the answer of the reason for the increased spasticity. The treatment is oral medications that improve tone, so baclofen, dantrolene, tizanidine, benzodiazepines. A lot of these require TUEs. So again, if you're taking care of these athletes, you got to look it up. And then injectable therapies with botulinum toxin and intrathecal baclofen, and tendon lengthening procedures if it gets severe. Peripheral nerve injuries are also very common. Traumatic neuromas and amputees, compression neuropathy, due to prosthetic fit, especially at the fibular neck and transtibial amputees. And then median nerve carpal tunnel syndrome is the most common mononeuropathy in wheelchair athletes, which again, if you use common sense, that makes sense because you're constantly gripping your wheelchair to propel it forward. From an MSK standpoint, adaptive athletes get all of the injuries that able-bodied athletes get. They just might not always be able to explain them, and they might not feel them the same way if it's occurring below the level of injury. And the overuse upper extremity injuries can affect people like wheelchair athletes significantly more because not only does it affect their sport, but it affects the way that their mobility and the way they get around if they have a shoulder injury. Osteoporosis and osteopenia could come up. These are treated the same way that they are in the normal adult population. Note that that's different. The Z scores and T scores are slightly different than the athletic population. Um, and then fractures are possible. And if it's in an insensate area, they might not even report that it's painful. So you just have to have a high index of suspicion, especially if you have someone who's like a wheelchair athlete and crashes or a sled hockey athlete and crashes, that they might have some pain in a location, but they wouldn't be in as much pain as you would expect with a fracture. From a concussion standpoint, this is just a case and then to point you to some resources. So if you're covering a wheelchair rugby event and you have an athlete with spina bifida, seizures, and a VP shunt, and they hit their head for concussion. And so like, how do you evaluate that athlete for concussion, right? Like you don't know their baseline you might not know their baseline cognition. They are not able to do any balance testing. And I'm not going to teach you, and I don't even have all of these memorized, like all of the ways to evaluate these athletes, but there are SCAT 5s and now SCAT 6s specific to athletes with different impairments. So if you're ever covering something like this, have it, print it off, make sure that you look at it again. So they have separate ones for athletes with spinal cord injury, absent vision, and then spina bifida as well. So quadriplegia versus paraplegia. You just need to know those exist. You're not going to get specific questions about them. And then athletes with intellectual disability and Special Olympics are kind of a separate subset of the adaptive sport athletes. And so intellectual disability is a limitation in both intellectual functioning and adaptive behavior, where their social and practical skills are not at the level that they should be, and intellectually, they're also not at the anticipated level that they should be. You have an intellectual disability if they have below average intellectual functioning by 2 years below their peers. And then limitations in two or more of the adaptive skills areas, which are like ADLs and everyday like social things. And typically this occurs before age 18. The biggest things with these athletes are athletes with Down syndrome and the issues that they can get. So if you did adult family medicine, you probably should be well versed in some of these. So cardiac wise, they get endocardial cushion defect, VSD, ASD, PDAs, pulmonary hypertension, have a lower peak heart rate. Vision-wise, they have cataracts, refractive error, glaucoma, strabismus, macular disease, and then ligamentous laxity anywhere, which can lead to hip instability, patellofemoral dislocation, and then atlantoaxial instability, which is probably what you'll get questions about. I've also seen questions about the cardiac issues. So endocardial cushion defect is commonly associated with Down syndrome, and that's something that is often tested. So what is atlantoaxial instability? You are probably going to get a question about this for better or worse. So that is when you have laxity of C1 on C2. So in the X-ray here, you can see as they flex forward, there is instability where C1 moves forward and C2 is pushing posteriorly to where the spinal cord would be coming down. And obviously the risk of this is quadriparesis or quadriplegia if you get hit in a contact sport. So it's actually present in 10 to 30% of athletes with Down syndrome, typically they complain of neck pain, deformity, fatigability, abnormal gait, clumsy, and then they can have upper motor neuron signs with hyperreflexia and clonus and Babinski. You need an X-ray and flexion extension in neutral. All kids are typically screened between 3 and 5 years old. And if the atlantodense interval is greater than 4.5 millimeters, I've seen that on tests, and it's abnormal. And then high risk sports need to be screened. So pentathlon, diving, any swimming if they're doing butterfly stroke or diving into the pool, high jump, gymnastics, soccer, judo, snowboarding, alpine skiing. That's pretty, you know, obvious of which things need to be screened. And athletes that have atlantoaxial instability can play in the Special Olympics. This is a Special Olympics rule. If they have a sign released by two physicians, I would never want to be one of the physicians that signs that release. But that is the Special Olympics rule. That's probably not on boards, but just FYI in life in case you ever get asked about this. All right, so we have some more questions and then we'll wrap up. So who wants to read this one?
I can give it a go.
Perfect.
And you have volunteered to help cover the local Paralympic training facility in town. You heard that several players on the wheelchair basketball team have been clamping their urinary catheters to gain a competitive advantage. What mechanism is giving them an advantage? My guess here is that we're referring back to the autonomic dysreflexia to gain that advantage. So, A, increased blood pressure from unopposed sympathetic discharge. I like that. B, decreased blood pressure from unopposed sympathetic discharge. That doesn't make sense. I would check that off. C, increased blood pressure from unopposed parasympathetic discharge. That also doesn't add up, so check that off. And D, decreased blood pressure from unopposed parasympathetic discharge. That itself makes sense, but I don't think that would give you an advantage, so I'd go with A.
Yeah, exactly. So this is inducing autonomic dysreflexia or boosting. So it increased blood pressure happens from unopposed sympathetic discharge. Just like remember that. And then remember T6 or above. And knowing one of those two will probably get you the answer correct. And with boosting, things that athletes will do, I don't know if they would ask you this, but you might see in real life is they will not cath themselves so that their bladder distends. They will not do their bowel program so that they're constipated. They'll put a tourniquet on their leg to cause pain, or even like people have resorted to like breaking toes and doing other things. And then if you do ever have an athlete with the symptoms, headache, flushing, uh hypertension, bradycardia, the first thing is to like sit them up, loosen their clothes, check their bowel and bladder. And most of the time that resolves it as long as there's not something else medically going on. And if those things don't work, that's when you give them medication. All right, next question. Hopefully I harped on this one enough.
Can go. A 15-year-old male with Down syndrome presents to your clinic for his pre-participation exam. He'll be participating in judo. Per Special Olympic guidelines, the patient will require a lateral cervical spine X-ray with flexion and extension views to rule out atlantoaxial instability. These X-rays will be used to assess the ADI. Which measurement of the ADI would disqualify the athlete from competing in a high-risk sport like judo? And D, 4.5.
Yeah, exactly. Just again, I hate being like memorize things, but this you could figure it out, right? Like everything is greater than this, whereas all the other thing, like all of these answers are greater than 1.5. So this might not be the best worded question. Um, but that 4.5 is just a number to know. And then the change in the atlantodense interval, those are the questions you're going to get about um atlantoaxial instability. They might ask the sports that you should be screened before. And so that those are just anything that are contact or would involve a blow to the head or the neck going into extension or the risk of falling. And then this is just a closer up view of that instability. All right, we have a couple more questions.
All right, so I'll go. So, which of the following is true regarding adaptive athlete when compared to their able-bodied counterpart? Wheelchair athletes are at a lower risk of fracture. Adaptive athletes are at a greater risk of physical, sexual, and emotional abuse. Wheelchair athletes have a lower risk of shoulder injuries. Entrapment neuropathies are uncommon in adaptive athletes, and adaptive skiers have a high incidence of injuries. I would say E, but also I would say B. I'm going to go with B.
Yeah, that's correct. So you did a really good job. Like you clearly crossed some off quickly and you made it down to 50-50. Um, that's what a lot of the boards is just how do you get this question to be manageable? Um, and we didn't cover either of these things, right? B or E. So you're like, oh man, I never studied that. I don't know. But then you think about, who are the people that are at risk of abuse? And unfortunately, those are people who are at a disadvantage or more vulnerable. So women, adaptive athletes, um, any athlete in general compared to, a coach or someone else in a position of power. And then with the skiing, disabled athletes actually have a lower incidence of injury than able-bodied skiers. In general, the incidence of injury in adaptive athletes versus the general, like versus an able-bodied athlete is fairly similar overall. The risk of having a medical event like at the Paralympic Games, so medical complication is higher in the adaptive athletes, and that would make sense, right? They have more comorbidities at baseline that put them at higher risk, so the risk of illness is higher. But the risk of injury is relatively the same, other than those specific differences where you're putting more stress through like your upper extremities when you're a wheelchair athlete, etc. All right, we just have a couple more. Who's next?
I can go again. The most common nerve entrapment syndrome observed in wheelchair athletes is, oh yeah, we talked about this. A, it's
Yeah,
median nerve with the gripping.
yeah, exactly. And again, even if we hadn't talked about that, think about how you could rationalize your way through. Like what's most common in the general population. Oftentimes it's the same unless you can think of a reason why an adaptive athlete would use their body in a different way than the able-bodied athlete. So A is correct. All right, I think this is the last one. Another autonomic dysreflexia. This is the last piece that they probably would ask you about is how do you treat it? What do you do?
So which of the following statements are true regarding autonomic dysreflexia? Spinal cord injury at or above the T6 level are unlikely. I think that's the opposite. Should be above. They should have an elevated blood pressure, so not B. Initial management should include head elevation and identification of noxious stimulus. Going with that one so far. And then perpetuated by hyperactive parasympathetic nervous system. And then symptoms include tinnitus, sweating below the injury or level of injury, and nausea. It's not E because they would not be sweating below the injury. I would say C.
Yeah, correct. And you got a little caught up on D, but it's a hyperactive sympathetic, not parasympathetic. So good. All right. Oh, I lied. Sorry. This has to be the last one. This is actually the last one. We didn't talk specifically about this, but I think hopefully can use common sense to get your way through.
I can do it. So for individuals with limb loss, amputation, which of the following statements is true? A, participation in sports and recreation improves prosthetic use and function. That sounds good. B, participation in sports and recreation improves quality of life. That also sounds good. C, participation in sports and recreation can improve body self-image. That's probably true. D, participation in sports and recreation can improve proprioception. That is also probably true. So I would go with E. All of the above are true.
Yeah, correct. Yeah. So again, a lot of these are common sense or things that you would think about in an able-bodied population is going to apply to the adaptive athlete population. And that's it. Any adaptive athlete questions? The biggest things, autonomic dysreflexia is going to get you a question for sure. And then there's probably going to be a question about athlete with Down syndrome, either cardiac related or atlantoaxial instability related. No
I for
question.
sure had a question about a wheelchair-bound athlete, and they were an above knee amputee, and I had a whole list of things about them, and they said which puts them at greatest risk for heat illness or something to that extent. It was very complicated.
It was an amputee
Oh yeah.
or
Yeah.
a spinal cord injury.
No, it was an amputee who competed like in wheelchair basketball. Like so they had, I think, maybe bilateral above knee amputees. I don't know. It was some crazy scenarios. Like, you got to be kidding me. Why are we sitting here discussing what factor about the athlete puts them at risk for heat illness? How about you ask me how to treat the heat illness in this athlete? And I think it was literally like a wheelchair basketball player who's not even outside. Like, it was just something so out there.
Yeah.
It was pretty
In that
special.
scenario, it's probably the same as the able-bodied athlete.
Yeah,
Yeah.
it was a lot.
I would be more inclined to think that it would be a spinal cord athlete, and then the answer would be that they don't sweat below their level of injury. But with the athlete with prosthesis, it either would be the like extra, like they have the if usually if they're amputees, they're not in a wheelchair with their prosthesis on. And so then you're thinking of them similarly to an able-bodied athlete.
Yeah,
Interesting. I haven't seen that before, but
either had I. I think I laughed out loud when I started reading the question because it just got more and more ridiculous as it went on.
yeah. There are definitely questions on boards that you're going to have that reaction to. Like, I mean, it's been a few years since I took it, but I remember leaving there and I was like, in my fellowship, I helped Dr. Finoff write the board chapter or the review book chapter on exercise physiology. And I left there and I was like, there were so many exercise physiology questions that I didn't know. And I was like, well, everyone else is screwed because they probably all studied the chapter that we wrote. And then I did fine on board. So there are going to be things that come up that are like that, and you just gotta just answer the best you can. And they throw out a bunch of questions too. So don't get too caught up in the ones that you don't know and you're like, this is really off the wall. Like, I wonder if that question was an experimental one.
That's what I chalked it up to.
Yeah.
Yeah. Thank you so much for your time today. We greatly
Yeah.
appreciate it.
You're welcome. Thanks for having
Anybody
me.
else with questions before we let her run back to seeing patients? Nope. All right. Well, thank you for your time. Good to see you.
Yeah, good to see you.
Everybody have a good Thursday. And just a reminder, no lecture tomorrow. This is counselor lecture for the week. So Allison was kind enough to donate her lunchtime.
Yeah. Awesome. Thanks.
Thank you.
We'll see you.
Bye.
Bye.